Williams.
Yeah, thank you so much, Mark, for that introduction. I'm really glad to be here joining all of you here in the room and then, of course, online. Tragedy yesterday affected us in the emergency department too, and we're all grieving a bit for that. Bear with me, I worked last night and then biked here, so I am gonna do my best to stay lucid for you. David Carroll asked me to kind of do this in two parts. So one is a quick summary of altitude illnesses, which I will run through at whatever speed you want. Ask me to slow down or go into depth. But I think we should spend some time talking about some specific incidents and cases that have come up. And then I definitely want to leave enough time for questions at the end, which is why I'm here. So first, a couple definitions. So some of this data comes from the Wilderness Medical Society and from the wilderness medicine textbooks. And most books define altitude into kind of three categories. And so you'll notice that here in Arizona, we have mountains that reach the high altitude category. We don't quite reach the very high or extreme altitude categories. And then from a physiologic standpoint, it's real important to recognize that the hypoxia that people experience at altitude and the way that it affects the body, it's not the same as your run-of-the-mill hypoxia that you could see from someone with a bad pneumonia and they're just not exchanging gases well. And that kind of hypoxia, or someone who's drowned or strangled, those kind of hypoxias are different than the kind of hypoxia you get at altitude. And that's because that's a hypobaric hypoxia. It's not something that we normally physiologically see. When I teach this to undergrads and even to medical students, we have to spend some time belaboring what partial pressure is. I'm assuming that most of the scientists and researchers here understand what partial pressure is and the difference between partial pressure and concentration, which sometimes gets confusing. People think the concentration of oxygen decreases as you go up. It does after about 35,000 feet, but up to that point, the concentration is 21% of oxygen. So the concentration is the same at altitude. It's just that the partial pressure that oxygen is exerting on things around it, including the alveoli of your lungs, is lesser. And that's what leads to all the physiologic problems that we see. And here's some of the responses that your body has. And I'm not going to spend a ton of time on these, but just recognize that all the systems of your body respond to that hypobaric hypoxia. And some have slow responses and some take a little bit longer. And we call that longer acclimatization. So probably the biggest one is your ventilatory response immediately starts to increase. So everyone feels a little bit winded. That's your body starting to acclimatize and deal with that hypobaric hypoxia by simply increasing your respiratory rate. There's some really cool reasons that happens, and one of them is to displace carbon dioxide to increase a little bit more space for oxygen. And so you will result in increased oxygen, the relative pressure there, because you have more of the CO2 displaced by hyperventilation. But ultimately, that changes the pH of your blood and it gets a little more alkalotic. And so your kidneys have to compensate for that by excreting bicarbs. You start peeing more at altitude. Well, if you're peeing more and you're breathing more, you're losing a lot of water. And so that's why staying up to date on your hydration status at altitude is really important. Blood flow increases to your brain because your brain, all it knows is that it's just not getting that same oxygen effect as it normally would. And when your brain is suffering from hypoxia, it has to increase flow to the brain. And that can increase a really substantial amount, like 20%. Your heart will increase its cardiac output, usually just does that by increasing its both its squeeze and the rate. And then your blood changes a bit, which we'll get into here a little bit. Ultimately, over time, your blood gets a little bit thicker. But immediately it's going to get thicker because you're just losing more plasma. So there's kind of a twofold reason that it thickens at altitude. One is just because you're peeing a lot more, so you have less water in the blood, so less plasma. And then secondly, you start to actually increase the amount of red blood cells circulating, but that takes longer. That takes days to weeks. So most of those responses that we talked about, at least the ones I focused on, are kind of the early short-term acclimatization, but there are some longer terms ones which I mentioned: the increased red blood cells, the mass of the red blood cells, the amount of hemoglobin that they carry, the amount of oxygen they can hold on to, increases. Capillaries start to get a little more dense. And the thing that's using up all the oxygen in your body, like muscle, actually decreases to become a little bit more efficient. So you'll actually lose muscle mass at altitude. Probably not to any considerable amount at the altitudes that we're experiencing here in Arizona, though. So if you could sum up all of the pathophysiology of what's really going on and causing all of our altitude illnesses in one picture, it would be this leaky pipe. So basically you have permeability that increases in the blood vessels, and then you have hydrostatic forces that are pushing against that cause plasma to leak out. And that leads to all of the problems that we're going to see. You'll start seeing this first with edema, and I like this picture. This is a woman, I believe that she was at Everest, but this is a before and just a few days later, and you can see how much puffier she looks. And that is a very innocuous phenomenon. So the edema, a little bit of swelling. Some people at altitude will notice that their hands feel a little bit puffier, their feet feel a bit puffier. But the reason I like that is because that's showing on the outside what's also happening on the inside. And so it's a nice window to what's going on. And so that leads to some of the illnesses that we'll talk about. And the first one is acute mountain sickness. And this by far is what you're going to be experiencing at your altitudes. And what's really going on pathophysiologically is a little bit of swelling in the brain. And once it reaches a critical threshold, it changes from acute mountain sickness to another condition we're going to talk about here in a second. But I think it is kind of cool to realize that even before it crosses that threshold, the symptoms that are causing you to have acute, the physiology that's causing you to have acute mountain sickness is because your brain is swelling. And you're going to start feeling headache. You're going to feel nauseated. You're going to feel weak, dizzy. Sleeping difficulties used to be one of the criteria for acute mountain sickness. And here's if you wanted to actually score it. So if we are scoring someone for acute mountain sickness, there's the criteria that we use. And based on that, you have mild, severe, moderate to severe acute mountain sickness. They took sleep difficulty out of it. What they found is that they could remove it and not really decrease the sensitivity of this test, but improve the specificity. And a lot of people were having difficulty sleeping without acute mountain sickness. And so they figured, let's just separate it completely. And so you can see how severe this has to get before it gets really severe. So people are actually vomiting. The headache is incapacitating. The weakness is incapacitating. People have a hard time maintaining posture. Okay, so it can get really severe. The number one treatment for any altitude sickness is descent. That is, if you could sum up the treatment in one word, it would be to descend. People will immediately start feeling better. So that condition, that spectrum of illness, of altitude illness from acute mountain sickness, and as the brain swelling gets more severe, it can reach a point where you kind of cross this Rubicon of neurologic function. And now you're having something called high altitude cerebral edema. And it just recognizes that edema has been developing, but now it reaches a critical mass where, in addition to the acute mountain sickness symptoms that I just talked about, you start developing altered mental status. So these people have a hard time with cognition, hard time with speech. Sometimes they'll be delirious, hallucinate. And ataxia is probably the biggest one. Ataxia is inability to control motor skills. So people won't walk straight, or they'll walk really funny, or they'll shake really bad. I've seen this a few times at altitude, and people often have to be helped along. They usually can maintain posture. They don't need to be completely supine, but they without help, they have a hard time walking. And I've also seen some really interesting versions of this where they still have motor control. Maybe fine motor is not great, but their speech is bad, but their judgment's completely gone. And if you spend thousands of dollars invested in summiting a mountain and it's difficult, and you're working really hard to get to the top of that mountain, and everything in you is telling you, I got to keep going, I got to keep going, got to keep going. And then all of a sudden you lose your executive function and you're having cerebral edema. You're still on an autopilot to go uphill. And it's pretty crazy. You'll see people that are being treated for haze, and they're being carried down the mountain, led down the mountain. And as soon as someone lets go of them, they turn around and just start walking, stumbling up the mountain. You can see how if you're not being observed in this situation, actually cared for, people die. It's because they just don't get off the mountain. They don't descend. So same treatment we talked about, which is descent, immediate evacuation. But if you think someone is suffering from haze, this needs immediate online medical direction. You definitely want to be talking to a physician or working with your local EMS to get someone down the mountain. And there are things that they could probably direct advanced medical provider to start giving the patient. So in this case, we would start steroids. I wouldn't delay descent to give someone steroids. So this would not be in lieu of descent. This would be in addition with descent, in addition to descent. Okay. Oxygen is never a bad idea in this situation as well. There are other medicines that we could give, but we don't need to get into here. So the next condition that we talk about with altitude illness is not on that same spectrum in the brain. This is now a new problem in the lungs, and this is called high altitude pulmonary edema. But the same processes that are going on with those leaky pipes in the brain that cause acute mountain sickness and haze, it's the same mechanisms as causing leaky blood vessels in the lungs. But we just have, it's a different name. We call it HAPE, high altitude pulmonary edema. The big thing about this is complete inability to tolerate any exertion at all. And you usually pick up on this because this is someone who is normally really fit, doesn't seem to have a lot of other medical problems. They seem to be doing fine. And then now they're at altitude and they just can't do anything. And I'm talking people who are very fit and have trained to climb mountains. And all of a sudden they get to a point where they can't even get out of their tent to eat or to pee. And they're just basically stuck there. And they feel like just the idea of getting up just makes them winded and tired. So initially, though, it can be kind of hard to distinguish from other medical conditions like anything that's affecting lungs. I've seen pneumonia at altitude, and it's hard to differentiate pneumonia from HAPE. And so in cases of HAPE, you would have to, at altitude, assume that it's HAPE and then start excluding other conditions. But again, like we talked about, the treatment for HAPE is going to be to descend. These people also require oxygen, and that's even more important than the other medicines. Oxygen is what's important for this one. They will definitely have lower oxygen saturations if you check it on their finger. And there's an X-ray for anyone in a medical. You'd be able to look at this and say, well, there's a lot of fluid in the lungs, but typically we would see that with a really giant heart, and we would associate that with heart failure. We'd call that cardiogenic pulmonary edema. So this is unique because it's a non-cardiogenic pulmonary edema. So there's nothing wrong with the heart looking at this. It looks totally fine, yet the lungs are still backing up with fluids. It's basically like heart failure without the heart failure. And the cool thing about this is once you descend this person down the mountain, within a very short period of time, they feel better, and this resolves very quickly. So like I said, descent is really important. They're going to need to be assisted. And one of the reasons that's really important, and you guys aren't hiking people down the mountain, you're just putting them in an ambulance, and that's what you should do. But anything that you can do to decrease the amount of exertion this person has to put forth is going to help them. So if you're backpacking, someone gets pulmonary edema, you don't want to have them carry their own pack down the mountain. You really want to split up their stuff and basically not have them have to do any extra work. The more work they do, the worse the edema is going to get. So things that make it worse are cold. So you want to keep them as warm as you can. And like I said, minimize exertion. Don't worry about the medications. But some of the medications, it frequently comes up, people ask, well, what's this thing about Diamox? You'll hear about Diamox at altitude. That's acetazolamide. So that is a medication that we can use to help artificially or more rapidly acclimatize people. And the way that works, remember how I talked about your kidneys having to pee off that bicarb? This forces your kidneys to pee off bicarb. So basically you can give it to somebody before they even go to altitude, and they're already starting to acclimatize before they even get to altitude. It basically gives them like an extra day's acclimatization, which is why it's really cool. And it does really work. Steroids we use to help cover up the symptoms. It doesn't prevent the pathophysiology. And then ibuprofen, of course, works great for headaches. There is a way to artificially descend someone. I don't think we need this on any of the mountains, so I'm not bringing this up to say, hey, maybe this is a good idea to have on our mountains or in our kits. But in places that you have someone at an altitude and there's higher probability that you're going to have such bad weather that there's literally no way to descend someone, you can artificially descend them by putting them in this. There's a little window there, but that's the only person's like connection with the outside world. Otherwise, they're basically stuck in this little bubble. And this guy here is pumping this, and if he stops pumping, that person quits getting circulating air and they suffocate. So, you got to tip your pumper. So the big pearls are, if you want to prevent altitude illness, gradual ascent, gradual acclimatization is key. Descent's the best treatment. And then if you start developing symptoms, don't keep going up. But I wanted to talk about some incidents that we have from the LBTO, Mount Lemmon, and KIT. So you don't have to read all this, but I can kind of give you the summary. So this one is just in this past April. There was a contractor at LBT who basically passed out. And he was out for about 10 seconds, but regained consciousness fairly quickly. He could kind of tell that it was going to come on before it happened. He thinks he did hit his head. So they went to the kitchen, they checked the pulse ox. It was between, it was about 90, and he maintained a pulse ox about 90, and his heart rate was a little quick, but then it decreased. His blood pressure was always okay. They got in touch with us at Banner, and we recommended descent. Obviously, they came down, and he appeared to be doing okay when they got down. So is this altitude sickness? Certainly could have been altitude sickness. And I'm going to give you all my caveats here at the end, but you can't say for sure this was, but at altitude, this could definitely be from altitude sickness, acute mountain sickness. And so this is that same event, but the incident report said that their corrective action was to check out the victim, check their pulse ox. They offered oxygen. They got a hold of us. They drove him down the mountain. They got checked out. But their long-term corrective actions would be to consider altitude acknowledgement and risk documents for anyone that's going to be presenting on the mountain, and then maybe revise our contingency plan with more updated numbers, which I believe has been done. And part of that is on our receiving end with these calls. I'm not always the one answering the phone. And so if the person who answers the phone isn't really up to date with we don't get as many calls, right? So if they haven't been notified about this, they may not know exactly who to forward your call to. So I believe what we've done is basically on the number that tells you where to call, just remind them and give them, there's 2 names that are listed there. Mine is the first one. And they know that they can reach me. And then they know that if I'm not reachable, like I'm sleeping during the day or something, then there's another person they can get a hold of. So
just not to, apologies for interrupting, but this is in particular to MGIO. I just want to stress that.
No, you're right. And David told me that. So this is kind of informational for the Mount Lemmon and KIT people. Yeah. So this is the other incident. That next one, this also happened in April. This was at KIT Peak, and this sounds like someone that basically had a panic attack at KIT Peak. Not much to say about this one. They escorted him off the mountain. They did fine afterwards. This person apparently had more of a severe anxiety at altitude. And so then the question is, well, could this have been altitude sickness that they also were feeling, that shortness of breath that you get with anxiety? But the person who was affected actually really felt like this was anxiety. And I would agree based on what I read about it. It didn't really sound like this is truly altitude. The third one we have here, this was in April. This is at LBTO. Another contractor felt like they were exhibiting altitude illness, and they actually felt like that was their problem. They were not feeling well, and they checked their pulse ox there between 82 and 92. Blood pressure is fine, pulse was fine, but the patient didn't look good. He looked pale, and they said he had slowed or slurred speech, and that really catches my eye, because why? What am I worried about at that point? Maybe HACE. So then my question would be, what other things are there that could fit HACE? And is this really how I would describe? I didn't see the patient, so I can only go by what was recorded here. And I'd be curious if when I saw the person, I would have also described it as slow or slurred speech, but it very well may have been. If there were no other neurologic findings at the time and the person was feeling lightheaded and weak at the time, then maybe I would attribute the slurred speech to just maybe hypotension or something. But they got a hold of us. We recommended going down. And basically, as the person went down the mountain, they felt better. Their pulse ox went up, and they're like, they look good, and they weren't pale anymore. So it's really hard to say that whatever was going on here wasn't due to altitude, because as soon as they came down the mountain, they felt better. However, what else were they doing? This person, as they're recognized of having a medical condition, my guess would be that they weren't exerting themselves anymore. They were probably seated, obviously seated coming down the mountain. So they had some rest. They were probably given water. They may have been given a granola bar. So there's some other things that were going on that also helped this person get better. So can you say definitively that this is from altitude illness? You can't, but 100% this person should have been descended down the mountain, because that's the only way you could treat altitude illness. But keep in mind, you're also treating other things there. So it could have been exhaustion, dehydration, malnutrition, things like that. And that's pretty much what they recommended here as well. The only thing here was they offered oxygen. I don't believe this one was given oxygen. And then this is at Mount Lemmon. There was a student who was up there and was feeling poorly, and they called the parents to pick up the student, and they were at home. They had no interventions recommended here. It's hard to say. This is on the second day of a multi-day. Could it have taken that long to kick in altitude symptoms? Of course it could. Sometimes they don't pop up right away, but it's hard to say, especially with a teenager. If this was a grade school, I don't know how old this was. But if this was really altitude related or not. And then the last one, again, is at LBTO. This is the only one that didn't happen in April. So maybe that's our solution there. Just don't have anyone come up the mountain in April. But this one, it was in July. This is at LBTO. And someone came to the kitchen, not feeling well. I'm not sure exactly what their symptoms were. I'm inferring that it was shortness of breath, but they said only experiencing problems when laying flat on his back. Well, I don't know what they mean by experiencing problems. So I'm guessing it's a shortness of breath thing, but the oxygenations were kind of low, like 80s to 90s. And so they had the person resting, and they basically said, we're just going to keep watching them overnight. Was that the right decision? Should they have just taken this person down the mountain? Well, in hindsight, it looked like it was fine to leave them on the mountain, because within 3 days, they felt completely better. And they felt like they had acclimatized over that period of time. So that's kind of interesting. That actually is appropriate if you follow Wilderness Medical Society guidelines for acute mountain sickness. It's not mandatory descent for mild to moderate acute mountain sickness. You can keep someone, you just can't go up. So if you're having mild to moderate acute mountain sickness symptoms and you want to just keep observing them at altitude, that's okay. And obviously if their symptoms are getting worse and they're starting to develop severe mountain sickness, then of course they need to come down the mountain. But I like this case just because we got to see the alternative, not just descend every single time. This person actually did feel better afterwards. And not much more that they had to add as far as corrective actions there. So to summarize here, there really is not a single reliable clinical or historical tool to predict altitude illness. There are some things that we can use to predict susceptibility, even there, it's hard to just say, here's this algorithm, follow this, and if someone's above this level, they're good for altitude, and if they're below, they can't go. That doesn't really exist. But if you were to talk to someone with experience and a medical professional, and they would go through the person's chart, they would see all their comorbidities, all the medications they're on, and then have, it's kind of an art. And they've tried to make this a little bit more algorithmic, measuring things like heart rate variability and pulmonary function. They have found some things that correlate. Maybe an Army's working on one right now that they're hoping will definitively say this is how we predict people who are going to have altitude illness. But nothing is ready yet. So up to now, we can't say, here's how you exclude people to be on the mountain. That just doesn't exist. What I can say is that anyone with a pre-existing medical condition that diminishes their respiratory rate, their oxygenation ability, their lung function, their heart rate, their blood pressure, any of those are gonna be at higher risk of developing altitude illness. And I can say that being at altitude is gonna make all of those other conditions exacerbate. So if you're at altitude and you have a history of COPD, and then you have shortness of breath at altitude, are you having HAPE or are you having an exacerbation of COPD? The answer is either. And so that's why that nuance justifies, I think, medical direction, because we can get in, start asking some of those more nuanced questions to tease out, okay, is this really an altitude illness thing, or is this a COPD thing? The treatment, though, especially if someone's not looking great, is going to be come down the mountain either way. Because if it's a COPD exacerbation and the altitude is making it worse, coming down will make them feel better. And of course, if it's HAPE or altitude illness, coming down the mountain is going to make them feel better. So I think we can end there as far as my spiel. But I'm happy to take any questions now, especially if you want to talk about any of the incidences. Yeah.
So you pointed out that we have high mountains in Arizona.
Yeah.
But astronomers are frequently going to places in your other categories, very high and sometimes even 18,000.
Yeah.
We have sites there. Are people who have had previous suspected altitude-related problems, is that indicative of future problems on future trips to the same location?
Yeah.
So if someone has a bad reaction on their first observing run to Mauna Kea, should the rule be you don't get to go to Mauna Kea anymore because you're likely to
it depends. If it's HAPE, if it's pulmonary edema, that has the highest correlation with repeat pulmonary edema. It's harder to say that with the mountain sickness. It really depends on if they were following the guidelines for rate of ascent. And so if they weren't following the guidelines for rate of ascent, which when you drive to Mauna Kea, you're not, you can't say that if they were to follow the rate of ascent next time, they would still have a problem. They may not. And so that's part one. Part two, which is even cooler to me, is as you age, it actually becomes less likely to occur.
That's interesting.
Yeah. So your brain shrinks as you get older, and so there's more room for swelling. So the young people, they learn faster. The synapses are still plastic, but they develop more mountain sickness. So and some people can train for it. Yeah. Good question.
You can unmute and ask him so.
We have a question on
Benjamin.
Zoom here. Benjamin?
Hi, thanks. Sorry, I came in a few minutes late, but I wanted to ask the question. So it's not uncommon for us to have somebody, perhaps a visiting observer, who, gets like mild AMS symptoms, like they have a headache on first arriving at altitude.
Yeah.
Or something like that. And, it's usually our response to this is to tell them to, rest and contact us immediately if they start to feel any worse.
Yeah.
And what I'm wondering is if there are, if that's the appropriate thing. Sometimes there's a little bit of contradiction between asking them to rest and observing them, because, you know, we don't have that many personnel, and so, you know, we can send them back to their room to rest, but then we can't
Yeah.
observe them. And so I'm wondering what the best, you know, course of action in the case.
Yeah,
like
I think a good middle ground would be if someone's having symptoms to the point that they're bringing it up. And so it's becoming, for lack of a better word, an incident at that point. They're raising a concern, they're voicing a concern. I think a good middle ground would just be to make sure that someone checks on them maybe once every 4 hours, every 6 hours. I don't think more than that is necessary. I really don't. And if someone's going back to rest and they're not checked on for, 24 hours, could they theoretically continue to get worse and worse and worse, develop haze? I think it's possible, but I think even that would be really unlikely. I think someone would get to have such severe symptoms that they would come out and say, I'm not doing good, I need to go down the mountain.
Yeah, okay, that's useful. It's more, I think it would be very rare for us to check on someone for, 12 hours.
And that brings up the good point that, not everybody needs to come down the mountain. And if someone's having mild symptoms, it is totally appropriate for them to stay on the mountain and just rest, chill, because overexertion is going to make them worse. But just stay hydrated, stay nourished. I think nourishment is often overlooked, especially because they're a little bit nauseated. They don't want to eat, and that just is going to make things worse. And then within 24 hours, they should really be starting to at least show some improvement.
Yeah, I'm really thinking about the case of person arrives at altitude, after driving up the mountain very quickly, and then walks around a little bit and gets a headache.
Yep. Yep.
So if it's something more, like more obvious kind of respiratory or circulatory symptoms, then our response is going to be more attentive.
Yeah, and then I would recommend that person with just, the headache at altitude, they take ibuprofen or Tylenol and caffeine if they want, helps with the headache. They just need to stay hydrated if they're using caffeine because it's a mild diuretic.
Yeah, I see Don mentioned something about hydration, which I agree is very important. People forget that because it's very easy to get dehydrated quickly at altitude.
Yeah, it is. I think we had a question back here too.
You had mentioned the medication that you can take in preparation. Is there anything else that you can do?
No, that's about it. There is pharmacologically, as far as things you can do to kind of prepare yourself. There have been some studies showing people spending time at altitude and then preparing for higher altitudes by just getting used to acclimatizing in general. That's more for long-term expeditions and really, really high altitudes for, the 10,000 foot ranges that you guys are going to here locally. But if you're going to really, really high altitudes, 18,000 or whatever, spending some time at altitude, even if people that have summited Everest, a lot of them only train at places up to 14,000 feet. Obviously, it's hard to train past that in the United States. And it seems to help, kind of just teaches your body how to acclimatize.
I have a Zoom here.
Yeah.
Okay.
Who is it?
Was that Mark?
I don't know.
Yeah,
I was going to just say, I'm sorry to interrupt. What I'd appreciate is if there are any further questions, please send them to my attention because we're going to have to close this. Dr. Williams, I really appreciate you coming in,
There's
but-
one last person that wants to ask a question.
Oh, okay. Go ahead.
I had a question. Are there any precautions that people who've had a heart attack and then stents put in, is it okay for them to be at altitude?
Yeah, it's okay. It would depend on their current active function. So if they just had a heart attack and they're still in the recovery period, I think that's a horrible idea. If they've had a heart attack way back when and now they're able to exert themselves to a moderate extent, like they could run a little bit, and they feel like they're better, then I don't see any reason they couldn't. But there's no hard and fast criteria for that. So just having had any prior cardiac problems doesn't preclude you from going.
Okay, thank you.
Yeah.
All right, again, thank you very much, Dr. Williams. And we will make, not only are we recording this, but we'll make actually the presentation available to everyone too.
Yeah. I'm happy to answer questions offline too.
Excellent, excellent. Thank you very much.